Okay, we're going to go ahead and get started. And the first bill that we have for hearing today is House Bill 2234. Reviser Abbott, would you like to give us a brief explanation on that, please?
Thank you, Madam Chair. I'd be happy to. And good afternoon, committee. House Bill 2234 relates to emergency medical services and the provision of medical oversight for emergency medical service providers. Current law provides that the medical protocols of an EMS provider shall be approved by a county medical society or the medical staff of the hospital that the EMS provider primarily transports patients to, or an alternative method if neither of those are available. The bill would define medical oversight as a new term in the EMS statutes to mean the reviewing, approving, and implementing medical protocols and approving and monitoring the activities, competency, and education of EMS providers. The bill would also require that each operator designate a medical director to provide medical oversight. So it would shift that responsibility from the county medical societies or hospitals to a physician or a medical director designated by the operator. Would also allow, if a operator is not able to designate a medical director, the EMS board may provide for an alternative procedure for medical oversight by a physician of that EMS provider. The bill would take effect upon publication in the Kansas Register, and I'd be happy to answer any questions.
Thank you, Scott. Are there questions for the reviser? All right, seeing none. Committee, the first person that I have up for this bill would be Joseph House, the Executive Director of EMS Board. Welcome to committee. This is kind of an exciting bill.
Thank you, Madam Chair, member of the committee, and I do agree. This is a very exciting bill. This bill, House Bill 2234, my name is Joe House. I'm the Executive Director of the Emergency Medical Services Board. And we do support House Bill 2234. It is a 4-year collaboration of coming together with the medical directors through multiple meetings, discussing with them, hey, the biggest question that came up is what is medical oversight? What does it come down to? And is this included? Is this excluded? What exactly are we supposed to do? And so we felt the best answer, the solution to that was defining medical oversight, and that definition that the Reviser Abbott mentioned is exactly what we landed on. The second piece within this bill that really is a problem that's been ongoing for multiple years is a process to timely and appropriately obtain that approval of a medical protocol. So I'll start with just what is a medical protocol, and it's a physician order. When they encounter a certain situation, this is the way that the physician wants that care to occur. That prevents or hopefully slows a phone call being made every single time that we encounter a patient. So in EMS, they encounter approximately 370,000 patients every year. If we were to make 370,000 phone calls over that year, that'd be a little burdensome on their time. So these written protocols speed that up. The two mechanisms are great. They worked very well in the mid to late 70s when they were instituted, but just over time, those county medical societies have started to kind of dwindle in numbers and activity. Their frequency they're not necessarily meeting as frequent as what they were. Folks are getting just additional responsibilities placed upon them. It's not that there's a lack of value. In fact, we have 5 very strong, active medical societies that we anticipate, even with the changes here, are still going to participate in that medical protocol approval process. But now acting as more of a role to advise that physician that's been appointed as medical oversight rather than to dictate how they're going to provide that care. And so recognizing that this was an issue, the legislature in 2010 advised or created the Medical Advisory Council, which was that third option that the reviser had mentioned. So in the absence of the first two, that local medical society or the hospital to which you primarily transport patients, if neither are available or able, that medical advisory, which is a council, a group of EMS physicians, would then end up being that mechanism to offer that approval. Well, this actually developed over the last 5 years a different question, and that came down to the fact of liability. So, example, we had an ambulance service primarily based out of Nebraska, transports patients up here in the northeast Kansas area and the extreme northeast Kansas area, that was actually seeking approval of their medical protocols from the Sedgwick County Medical Society in Wichita. So when the Sedgwick County Medical Society looked at this, they said, oh, it's great that we have these care protocols, but how do we know that these are applicable to those folks that they're transporting up in northeast Kansas? And they were a little bit concerned because they thought that maybe this carried some sort of liability to them for providing this direction without ever being able to provide that oversight, without ever being able to review the care that's being given. And so that led us ultimately to, again, House Bill 2234, which says, no, the physician that you have designated by your service is going to provide oversight as a Kansas physician, gives us an alternative if a Kansas physician is not available to them for the board to enter into a mechanism to ensure that physician level direction is maintained at that ambulance service level, and then gives them that opportunity to continue providing care in the overall intent that was present within that statute. So throughout all of this, the board has felt very strongly that EMS clinical care in Kansas has to be directed at the physician level. The fix in House Bill 2234 gives the flexibility necessary to adapt those two methods and appropriately places liability on the physician that's ultimately responsible for oversight and making sure that that care is appropriate. We would urge your support for House Bill 2234 and its favorable passage, and I'm happy to stand for any questions the committee may have at the appropriate time.
All right. Well, you are the only proponent outside of written only from Rochelle Colombo with the Kansas Medical Society. So committee, are there questions? Representative Lynn.
Thank you, Madam Chair. I'm just curious, for the medical protocols, is this an established list of protocols, or could they be case specific?
So, great question, Representative. They are case specific. We require them to have at least 20 different scenarios, which are the 20 most prevalent medical conditions that are seen. And then there are other items that may be specific to that region where they've developed protocol. Best example I can think of are our communities with refineries. Hydrofluoric acid is a horrible, horrible acid that does crazy things. They actually carry specialized medications to combat or reverse if you're exposed to hydrofluoric acid. Not necessarily prevalent throughout all areas of Kansas, but in those it is. That's one of those areas where time is definitely of the essence to start that treatment.
If I may. So this is not meant to be something that's done within a specific case, I suppose. Like, it's not meant to be done during a call, I suppose.
Correct. Yeah, they have that mechanism right now to call if something weird pops up, and they can call and ask for orders. These are designed to be written directives established way ahead of time.
Okay, thank you, Madam.
Representative Blacks.
Thank you, Madam Chair, and thank you for your presentation. I think the previous representative answered the bulk of my questions, and I'm assuming when you have that 20, for example, that you give of written protocols, then if there's something outside that parameters, then the EMS personnel would utilize a telephone, or could they do anything prior to contacting you or not? Is that part of the medical oversight?
Correct. And hopefully they're not contacting us, but contacting their physician or one of the hospitals.
Physician.
Absolutely. And these medical protocols, there is a generic just patient care assessment thing that covers the vast majority of contacts that they have.
Okay. Thank you for that. Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair. Thanks for being here, Joe, and sitting on your board. It's always interesting to see how this has evolved. And so I just want the committee to understand, and if you could explain that do some services have more than the 20 protocols, and how they can vary from region to region. Like up in northeast Kansas, we do carry the medicine necessary to reverse hydrochloric acid. because of the exposure to chlorine gas. But and that was a good example, but what other variances that could you touch on just so they can understand that these need to be specific by service? Thank you.
Absolutely. So there are definitely services that have more than the 20. The 20 is our minimum of going through in the adult and pediatric side of things. But we do have some very specialized protocols, especially when you start looking into the Children's Mercy Critical Care Transport deals primarily with children in very serious health conditions, such as respiratory conditions that may require specialized equipment, respiratory therapists, ventilator settings, things like that, where they understand from the physician when they anticipate these type of patients to be seen, here are the parameters that they would like them to operate under. It gives that preloaded scenario. The most protocols that any one service has, I believe, is 81 right now, where we go through. Each protocol that comes through is given to us to look at, to review, to make sure that it meets a standard. We have a national model clinical guidance document that kind of gives us those parameters for most of those conditions, which is being updated on a continual basis. To give some more examples of some of the things that are heavily specialized, farm-related accidents, injuries, not necessarily something that appear a lot in more urban area protocols, but are absolutely necessary within our rural areas of Kansas. Things, time-critical diagnoses, care is much different when you're 45 minutes to an hour from definitive care versus when you're 15 or 20 minutes from definitive care.
Thank you, and thank you very much for all your work on this, because I know it's been a journey. Thank you.
Thank you.
Representative Parker.
Thank you, Madam Chair, and thank you for joining us today. I don't know if it's ideal or not ideal to be the only conferee. I guess that means you get all the questions asked of you. Not being familiar with this issue from the past, I know you've talked about it took a while to develop this. Is that just trying to run through all the different scenarios like the Vice Chair mentioned? Are there other parties that this has to be negotiated with? What does that process look like, and were there other folks outside of EMS involved in putting that together?
Sure. No, that's a great question. So the discussion itself started off with, again, just medical directors asking, what is it that you're asking of us when we sign on that sheet? And so a lot of communication between the physicians themselves, the Kansas Medical Society, to ensure that we're covering the bases on that side. The EMS community, the Kansas EMS Association was involved. The Kansas EMT Association was also involved in these communications. We have an annual meeting to just gather and talk about legislative topics. This was at the top of that list for the last 4 years leading up to, we actually canceled last year's. And going through things. And trying to think if there were any other groups. We did reach out to the Wyandotte Johnson County Combined Medical Society to act as a test is going through. But it was really just those informal communications, those meetings at the regional level to say, hey, how can we best offer a solution to fix the problem you guys are talking to us about?
Thank you. Thank you, Madam Chair.
Representative Kelly.
Thank you, Madam Chair, and thanks for working on this. My question, you've answered it a little bit, but like in this last year of COVID, that's changed things tremendously. They kind of go together. Have you had to change protocols kind of on the fly, and can you get new ones in fairly rapidly? And the other, in instances of COVID or in my community where the hospital closed and every trip is a road trip, does that change protocols that an ambulance service has to do?
Right. So to answer the second question, yes, the distance does change protocols quite a bit. Again, a lot of difference between handling a critical patient for 5 to 10 miles versus, in your community's case, 30, 35 miles, sometimes upwards of 100 miles if they head south. And that's directionally, not conditionally. But and so There are some changes where you see that on the COVID front of things, there were definitely changes needed. Biggest being aerosolization procedures. So a person that has a breathing issue and is going to receive nebulized albuterol, having a nebulized treatment blowing and then coming back out in the back of the ambulance they identified actually let particles out that they probably didn't necessarily expect. And so protocols were adjusted to ensure that that off-gassing, if you call it that, was secured near the patient and not necessarily subjecting the remainders in the back or the remaining care providers in the back to handle that. We, unfortunately, stepped aside from looking at the protocol approval. If it didn't deviate in the spirit, the intent of the protocol, we didn't require them to gain an additional approval due to COVID. Technically, they should have gone back through with it being a change in that care direction of going through the formal approval process. But knowing that these bodies typically, not all of them meet regularly, some of them just on a once a year, maybe once every 2-year basis, it would have been problematic for many of our services to adjust quickly to the care as it was rolling out. And so COVID was a great example of where having this functionality would have proven very beneficial to a lot of communities and not necessarily forced us to find an alternative path.
Committee, further questions? Representative Turner.
Thank you, Madam Chair. So just understanding if I got this right or not. So what we're talking about is when an ambulance comes and loads a patient, that they follow, or even before they load the patient, they follow protocols that are established, as you say, well in advance. And currently that's done by these county medical society, medical staff of the hospital, and that you're saying that those numbers are dwindling and those folks have got other attention. So now we're going to shift that to this medical director, which is defined as a physician. Is that an individual physician?
That is, yes.
Named by that person that's in the ambulance?
No, named by the service itself as, and currently all ambulance services in Kansas are required to have a physician designated as their point of contact.
Okay, so it will be a person then, a single person?
Correct.
Okay, and often even though they have these protocols, then they need to make a timely call because something unique has happened in transport of the individual that they need to get information, so they would call this person then?
They would either call this person or sometimes at that point just ask the patient which hospital they were wanting to be transported to and then contact the hospital they're transporting to.
Okay, all right. Well, thank you. I'm sorry, Madam Chairman. I know I asked a couple of follow-ups. Thank you.
No, never apologize for asking a question. I'm the queen of questions in the building. So are there further questions, committee? All right, seeing none, thank you very much for being here today. Committee, that closes the hearing on House Bill 2234. And unless there is objection, I would like to work House Bill 2234. Is there objection? All right, seeing none. Representative Epley.
Thank you for the opportunity, Madam Chair. I would like to, for all the great testimony given, just say that we would like to see House Bill 2234 moved out of the committee favorably for passage.
Is there a second? Seconded by Representative Kelly. Motion by Representative Epley, seconded by Representative Kelly. All those in favor to pass House Bill 2234 favorably, aye. Aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Now, committee will turn our attention to House Bill 2259, which is permitting the use of expedited partner therapy to treat a sexually transmitted disease. And I'm going to have Revisor Abbott give us a brief explanation on that.
Thank you, Madam Chair. House Bill 2259, as the chair stated, is about the use of expedited partner therapy to treat sexually transmitted diseases. For members of the committee who are returning from last biennium, this may look familiar as it is very similar to a bill this committee heard and passed out to the House floor in 2019 on the same topic. So the bill would authorize the use of expedited partner therapy and prescribe some requirements and liability protections for the use of expedited partner therapy. The bill defines expedited partner therapy as prescribing, administering, dispensing, or otherwise providing antimicrobial drugs to a sexual partner of a patient who is clinically diagnosed by a healthcare provider as infected with a sexually transmitted disease without requiring a separate physical examination of the sexual partner. This would be limited to physicians, to APRNs, and to physician assistants to engage in this practice. Those who have the authority to write a prescription for these drugs. It would also define sexually transmitted disease as those that are designated by the Secretary of Health and Environment under current statutory authority to adopt rules and regulations designating infectious diseases. So the requirements and kind of guidelines for using expedited partner therapy are in subsection B of the bill, starting at the end of page 1. It allows a healthcare provider to provide expedited partner therapy if, in their professional judgment, the patient's sexual partner is unlikely or unable to present for examination, testing, and treatment. It also has requirements about distributing some written materials that are provided and prepared by the Department of Health and Environment. And also has kind of a time restriction on the use of expedited partner therapy for those sexual partners who may have been exposed within the 60 days immediately prior to the patient's diagnosis. The bill includes some liability protection for healthcare providers and pharmacists for civil damages for actions in good faith compliance with the provisions of the bill. And also provide some protection from disciplinary action by the associated regulatory boards, healing arts, nursing, pharmacy board for actions in good faith compliance with the section. The bill also requires the KDHE to include some information in written materials for distribution by each healthcare provider providing expedited partner therapy. I won't go too far into detail on that, but there is a list of that information, warnings, disclaimers, information about the drugs and the treatments that have to be provided to each patient. It also includes notification for the partner of the patient who is actually being treated by the healthcare provider. The bill would allow the Secretary of Health and Environment to adopt rules and regulations necessary to implement the section and would take effect on July 1 of 2021. And I would be happy to take any questions.
Thank you, Revisor Abbott. Questions, Representative Barker?
Thank you, Madam Chair. Is there a limit to the number of sexual partners? Question.
Representative Barker, there is not a limit on the number of partners in the bill. The only similar kind of limit would be that time restriction that I mentioned of those who may have been exposed in the past 60 days of the patient's treatment.
I remember this bill from 19 or I guess 20, whenever it was. I think at that time, the testimony at that hearing was since there was no limit and that you were having nurse practitioners or doctors prescribing medication, it could be as many as 4 or 5 if they would list that. And there was some concern that there should be a limit to the number of partners they're prescribing medication to that they've never seen. Thank you for that. Thank you, Madam Chair.
Further questions for the revisor, Representative Blex, and then Representative Lynn.
Thank you, Madam Chair, and thank you, Scott. Is this a voluntary for the partners, or is this something that's mandatory? In other words, would they be required if KDHE makes that regulation, would they be required to mandatory treatment, or they could refuse, I assume?
Yeah, Representative, there's nothing in this bill that would require a partner that's identified for treatment to undergo the treatment.
Thank you for that.
Representative Lynn.
Thank you, Madam Chair. I'm wondering, I don't see anything about whether or not these can be prescribed to minors. Or the extra ones be prescribed for minors.
Yeah, you're correct. There is nothing in the bill about kind of characteristics, whether it be age or otherwise, of the partners who are receiving the therapy.
Thank you, Madam Chair.
So Scott, a minor could take treatment without a parent knowing. Is that correct?
There may be other provisions of law that would kind of speak to that subject. There's nothing in this bill that makes special provision for that kind of relationship between the healthcare provider and the patient if they are a minor.
Okay, I think I'd like you to take a look at that between now and the time we work it. Are there further questions for Revisor Abbott? All right, seeing none. The first conferee committee that I've got is Dr. Kimberly Swan online with us. Okay. There was concern that she would have to step away and go into surgery, so that apparently that's happened. So please consider her testimony as written, proponent for the bill. Next, I have Phil Griffin, I'm going to get this out yet, Director, Bureau of Disease Control and Prevention, KDHE. Phil?
Good afternoon, Chairman Landwehr and members of the committee. My name is Phil Griffin, and I serve as the Director of the Bureau of Disease Control and Prevention at the Kansas Department of Health and Empowerment. Thank you for the opportunity to provide supporting testimony relative to House Bill 2259. We strongly support this bill and the use of expedited partner therapy, hereafter referred to as EPT, for the treatment of sexually transmitted infections. Prior to the SARS-CoV-2 pandemic, the most common reportable infection each year in Kansas has been sexually transmitted infection, chlamydia. During the calendar year 2019, 15,283 cases of chlamydia were diagnosed in Kansas, with 98% of cases occurring in people of reproductive age. Left untreated, chlamydia can result in infertility, ectopic pregnancy, pelvic inflammatory disease, and in rare circumstances, life-threatening sepsis. One of the most significant risk factors of these complications is repeat infection, and most repeat infections are due to re-exposure by an untreated partner. The use of EPT removes barriers to ensuring the prompt treatment of potentially infected partners, thus reducing the risk of reinfection. Nearly 70% of all chlamydia cases are diagnosed in women because women are more likely to seek out preventative health services and have symptoms of infection. Men, by contrast, are less likely to have routine screening or to exhibit symptoms of infection. EPT allows the partners of infected individuals to more easily obtain preventative treatment. Data shows us that the more barriers that can be removed to seeking care, the more likely it is that patients will obtain the necessary care. EPT is supported at the national level by numerous organizations, most notably the Centers for Disease Control and Prevention, as well as numerous professional organizations of medical practitioners. In addition, EPT is currently supported in 45 states, including in our neighboring states of Missouri, Colorado, Nebraska, and Arkansas. The medications recommended by the CDC for treatment of chlamydia are safe oral antibiotics with very few side effects or contraindications. EPT has been common use in most states for more than a decade with no major adverse events reported, further demonstrating the safety and efficacy of the treatment. Economic modeling recently published by the CDC estimates that each male chlamydia infection incurs an average lifetime cost of $46, and each female chlamydia infection incurs an average lifetime cost of $262. According to our recent search of prices of generic medications online, a single dose of azithromycin as EPT for chlamydia cost less than $10. Using these estimates and our own surveillance data, chlamydia infections burden Kansas healthcare systems with an average estimated total nearly $3 million in 2019 alone. Given that chlamydia infections have increased by an average of 7.4% from 2015 to 2019, these avoidable medical costs can reasonably be expected to increase by more than $150,000 each year that growth trend continues. In summary, The practice of EPT is a proven medical practice that Kansas providers are interested in conducting, but which is disincentivized by the lack of legal protection that almost all states provide. The treatments are safe and cost-effective ways to prevent STD-related infertility and other serious long-term consequences in women. Simply put, House Bill 2259 provides a common-sense way to protect the health of Kansas by allowing innovative medical practice. I thank you for that, and I would offer to you the additional pieces with the written testimony is 2 maps. One is the map of the United States showing the areas that are where this is already in place, the 45 states, and you'll see the 4 that have a potentially allowable, meaning that there's nothing in statute that would prevent it from a practitioner from doing it, but there's no legal protection. And then the 1 state where EPT is absolutely prohibited, being South Carolina. And then also the county by county 2019 data for chlamydia. And I thank you for the opportunity to testify.
All right, thank you. Committee, are there questions? I'm not quite sure why we're getting feedback. Representative Epley.
Thank you, Madam Chair. Phil, thanks for being here today and testifying. And my question is pretty simple. In the states where they've had EPT in force for several years, a good length of time, has it had a positive impact on their chlamydia rates or their rates of STDs as it relates to chlamydia, sir?
Yes, there are declines. It's a little difficult to fully qualify that, but we can certainly see the data in those states where there has been decline in chlamydia rates.
And one last question, Chair, if I may. So the rates of chlamydia in the state of Kansas, I know are going up steadily, and I don't know, we banner around words pandemic, epidemic, but I mean, it's certainly increasing, and we're just trying to figure out ways to stem the tide, and that's the purpose of this bill. Phil, is that correct?
Absolutely, Dr. Epley.
Thank you.
Representative Blacks.
Thank you, Madam Chair, and thank you for your testimony. And maybe this is a question for the reviser, but I notice on the bill there that the sexual contact with a partner and who is able, and the verbiage says who is able to be contacted and identified by the patient. Do you know who's responsible for identifying that person and contacting them? Is a healthcare provider, or is that the patient's sole responsibility? And if so, I guess I see some issues. I see some issues that might have a healthcare provider. How do they collect for that, fee for writing a prescription to somebody they didn't ever see?
The patient himself is the one who's responsible for providing the identification of the partner and would carry the prescription to them or have them come in and pick it up from the physician.
Thank you for that. That clarifies it.
Representative Reese.
You're muted.
Sorry, thought I was unmuted. Phil, in your statement, you indicated the cost differences between a woman being diagnosed with chlamydia versus a male. What are the differences? I mean, I can only imagine what they are, but I'd like clarification on
that. Chair Landwehr, I have the STD Director, Scott Strobel, in here with me. Is it okay if I defer that question to him to more specifically answer?
That would be fine, thank you. Just have him state his name for us and do what?
Thank you, Representative. My name is sorry. Yes, my name is Scott Strobel. I'm the section chief over STI HIV surveillance and intervention. Representative, the difference in cost, the average estimated lifetime cost is due to severe health complications that can occur as a result of untreated chlamydia infection, which are unique to women, such as pelvic inflammatory disease, ectopic pregnancy, and infertility that much more commonly impact the lives of women infected with chlamydia as opposed to the men.
Okay, thank you.
Thank you.
Welcome. Further questions? All right, seeing none. Thank you very much. What, who? Oh, I'm sorry, Representative Parker. I keep trying to pretend.
Thank you,
you're not
Madam
there.
Chair. Just have to every now and then remind you that I'm here. Phil, I want to follow up on Representative Epley's question. You know, he asked about sort of the positive effects we've seen in other states, and I think you mentioned in your testimony 45 other states have this policy. Have we seen any adverse effects in those states?
There have been none reported. Like other conditions like this, adverse events would be reported to the VAERS system. And there's been no, or to the CDC adverse event systems, and there have been none associated with EPT that we're aware of.
Thank you, Madam Chair.
So you're asking me, Representative Parker, to look to my right. Are there any further questions for Phil? All right, seeing none, thank you very much, Phil, for being with us here today. And committee, you will also notice that there is 1, 2, 3, 4, 5, 6 written proponents for this bill. Is there anyone that I did not call on that expected to be called on today? All right. Seeing none, we'll close the hearing on 2259, and I'm thinking there may be an amendment, so we will not work that bill today. Next, I will open up the hearing on House Bill 2281, establishing and implementing 988 as the suicide prevention mental health crisis hotline in Kansas. And Revisor Abbott, if you'll explain, please.
Thank you, Madam Chair. House Bill 2281 would establish 988 as the suicide prevention and mental health crisis hotline in Kansas. This is based on some federal legislation that passed and was signed into law near the end of 2020 to kind of establish the framework for the 988 hotline on the federal level. And this bill would primarily accomplish implementation of that hotline for the state of Kansas. So this is implementation of the National Suicide Prevention Lifeline, which is a national network of local certified crisis centers providing emotional support to people in suicidal crisis or emotional distress 24 hours per day, 7 days per week. The bill would impose some requirements on KDADs as well as hotline centers and telecommunications providers in the state of Kansas as they relate to kind of the establishment and operation of this hotline. So you'll notice throughout the bill, there's kind of a date cutoff where a number of actions have to be completed prior to July 16, 2022. That kind of looks like the anticipated go live date for all the systems on the federal level for this hotline to begin operating on a full-time basis. So there are actions imposed and requirements imposed on all three of those groups prior to that date, and then some kind of maintenance and reporting requirements that continue on after that July 16, 2022 cutoff date. So KDADs under the bill would be required to designate a hotline center or a network of centers to provide the crisis intervention services for the hotline, create the system for information sharing and communication between all of the crisis teams and the emergency response systems that are necessary, convene the mobile crisis teams that would be responsible for responding to calls to the 988 hotline where necessary, and some training and coordination and guidelines establishment for the operation of the hotline and kind of all the parties involved in operating the hotline. Would also require hiring a statewide suicide prevention coordinator and creating an advisory board to provide guidance to KDADs and to make improvements and recommendations for the hotline centers in the operation of the hotline. The hotline centers that are contracted or are providing the services under the hotline would be required to establish an agreement with the national Lifeline system for participation within that network, meet the training requirements established by KDADS, enter into MOUs with local service providers to be deployed according to the guidelines established by KDADS, and kind of do a lot of the work of setting up the system of how those calls are routed and how those services are provided to persons who are calling into the hotline kind of on an as-needed basis based on the call that's coming in. And then also similarly has some continuing requirements after the go live date to receive those calls, deploy services, coordinate all of the access to services that are necessary, referrals and follow-ups and things of the like to coordinate providing services to people who are calling in. Third, the bill also imposes requirements on telecommunications providers to establish 988 as the unique number that you dial to reach this hotline and complete all of the changes necessary to telecommunication systems for that designation to happen. And also establish a system for collecting fees and remitting those fees to a newly created fund that would be used for the purposes of operating and maintaining the hotline. So Section 4 of the bill addresses that fee more in detail. This is kind of similar to the 911 fee that's currently imposed by law. It would impose a 988 fee in an amount of 50 cents per month per subscriber of telecommunication services, not on prepaid wireless service. That money would all be deposited into this newly created fund for the purposes of funding hotline operations and activities. So Section 5 creates that fund and kind of sets out those requirements and what the money would be spent on. And the bill would take effect upon publication in the statute book, but remember that July 2022 date is kind of the date when everything starts operating full time. And I'd be happy to answer any questions.
Are there questions for Revisor Abbott? Representative Reese, you have a question?
I do not.
All right, thank you.
I'll take my hand down.
Okay. Anyone else
Sorry.
with a question at this time? All right, thank you very much, Scott. We appreciate it. So the first person I have up will be Andy Brown, the Commissioner of Behavioral Health Services with KDADS and committee. Because of the number of conferees that we have on this bill today, we will limit everyone to 2 minutes, or they're pretty close, in order for us to get through it. So welcome to committee, Andy.
Thank you, Madam Chair. Trying to get my camera on here. My name is Andy Brown. I'm the Commissioner for Behavioral Health Services at KDADS. And I wanted to start by saying that this bill offers us a real opportunity in this state to work on a lot of the modernization goals that we have for our crisis system. As you're aware, like, we have been working towards the goal of trying to make both suicide and mental health crises something that are less impacting on our overall system of care in this state. Part of the reason that the bill's in front of you today is because we do have sort of a quick reaction time to this federal legislation that passed in mid-October. If we're going to have any funds available to implement this system in Kansas, we really need to identify a funding source for that, and ideally be able to collect those funds prior to the implementation date next July. I do think that there are a lot of really strong points in this bill, and you can see in my written legislation how this connects to our current system. If a caller calls the 988 number, they'll receive those services from the people on the phone. If there's additional services that are required, that's when there's an opportunity to dispatch to our mobile crisis program that's in the governor's budget. And then once we have those folks dispatched, if there's a need to screen them to go into a hospital, those mobile response teams would then have the ability to establish that service in the community. And all of that is set up in a way that reduces the impact on law enforcement, reduces the impact on our local hospital emergency rooms and our EMS staff. Additionally, by having a 3-digit number, 988 helps reduce calls to 911 for mental health emergencies. In all, I think this bill is a win-win bill for the state. I think we end up in a situation where we can use these to help fund many of the projects that we've wanted to fund in Kansas for a long time, and a lot of the things that have come out of the Mental Health Modernization Reform Act related to crisis services.
All right, thank you, Andy. You did pretty good on that. I appreciate that. And we'll go through all of our proponents, and then we'll come back for questions. Thank you.
Excellent. Thank you.
Next up, I have Diane Zolick, Director of Injury and Violence Prevention with KDHE. Diane, are you with us? Are you unmuted? Okay, I think while we're waiting on Diane to get her online, is we'll bring Kyle Kessler on, the Executive Director.
This is Dana. Are you able to hear me?
Are you here now? Turn your speaker off, please. Nope, your volume's not on. You need to unmute, but make sure your volume is off on your computer. Why don't we work on that, Diane, and then we'll take and come back to you if that's all right. All right. Next, I've got Kyle Kessler, Executive Director, Association of Community Mental Health Centers of Kansas. Welcome to committee, Kyle. 2 minutes.
Good afternoon, Madam Chairwoman, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear here this afternoon in support of House Bill 2281. This is one of the recommendations out of the Mental Health Modernization and Reform Committee. Was actually the highest recommendation out of the Prevention and Education section of the Policy and Treatment Working Group. So this is something that the group felt very strongly about getting past this session. And for our association, this is the 5th year in a row that we've come before the legislature referring to suicide as a public mental health crisis. So we first started talking about it in 2017 in Social Service Budget Committee and have continued in the conversation. You'll see by our testimony, which looks like this, that there are a couple graphs that reflect the challenges relating to the suicide epidemic in Kansas. And 2019 calendar year, according to KDHE's Summary of Vital Statistics, was the first year that we not only saw a freeze, but a reduction in loss of life to suicide. And we believe that this legislation could help move us even further down the track of reducing loss of life in Kansas by suicide. So with that, I would stand for questions at the appropriate time.
All right, thank you very much. Next, I have Monica Cruz, Vice President for External Programming, Kansas Suicide Prevention Headquarters. Welcome to committee, Monica. If there's a light on there, you are.
There we go.
Okay.
Thank you, Madam Chairperson, committee members, for this opportunity to speak with you about HB 2281. I stand before you as the Vice President of the Kansas Suicide Prevention Headquarters. We are a national suicide prevention lifeline provider for all 105 counties in Kansas. We are the only agency to do so in 104 of those counties. I cannot tell you how pleased I am to see the committee taking this bill under consideration. We know that our services are effective, evidence-based, and life-saving. Every year, over 20,000 Kansans call the National Suicide Prevention Lifeline looking to make a connection with someone who can address their concerns right away. We know, based on research and based on the moving testimony of each and every one of my counselors, that we are succeeding in making those connections and keeping folks safe. We're able to resolve so many of those conversations with a collaborative safety plan. We're able to partner with our fellow Kansans in thinking about how to keep them safe. And we know that in July of 2022, when 988 will come to Kansas, that more of our neighbors, more of the citizens of this state are going to reach out for help. We know that it will be an easier to remember number. We know that some folks who may have felt like they had no other option than to call 911 because they or a loved one was in mental health crisis, is now going to get connected to a professional who understands the mental health crisis right off the bat. We know that we're going to have the opportunity to get a mobile team out there, someone who is able to engage on that mental health crisis in the moment without having to take a pit stop with a law enforcement officer or an emergency department or jail. We're excited about this opportunity, and we know that we need to get ready. And that's why we're here today, asking you all to help us have the resources to meet those needs of Kansans every day. And I can stand for questions at the appropriate time.
All right, thank you very much. Next, I have Dr. Cheri Vaughn, Executive Director of the National Alliance on Mental Illness.
Good afternoon. My apologies for stubborn webcam this afternoon. Madam Chair and committee members, thank you for this opportunity to speak in support of House Bill 2281. NAMI Kansas is a statewide organization of the National Alliance on Mental Illness, and we echo these very statistics, common sense logistics, concerns, and need as previously shared by Kyle and Monica. As shared in my written testimony, the reality is that 5 Kansans are impacted by mental health conditions. So that means 5 out of 5 Kansans need House Bill 2281. So NAMI Kansas supports and advocates for House Bill 2281 because it is more than a number. It's also about respect and dignity. The call for help should not result in trauma or tragedy. People in crisis deserve to get the right services at the right time, and they deserve those services to be respectful, dignified, and effective. 988 crisis response system can change how we respond to people experiencing mental health crisis and improve their outcomes toward mental health recovery. On a final note, as stated by Commissioner Brown, House Bill 2281 is perfectly aligned with the strategic framework for modernizing the behavioral health system. And Madam Chair, we thank you for your work and leadership on this project and serving as the chair on this special committee. This concludes my testimony. We're excited for the future of mental health care that House Bill 2281 will provide for the 5 out of 5 Kansans who are impacted by mental health conditions. Again, thank you for your consideration and this opportunity to share with you today.
Thank you, Dr. Vaughn. I'm going to try to go back to Diane Zolick with KDHE.
Hello, are you able to hear me now?
Yes.
Oh, terrific. Thank you, Madam Chair and members of the committee, for the opportunity to provide supporting testimony for House Bill 2281. My name is Dana Zolick, and I'm the Director of Injury and Violence Prevention Programs in the Bureau of Health Promotion at the Kansas Department of Health and Environment. And in light of brevity, I would just like to share with you some data on the serious issue of suicides in Kansas. Between 1999 and 2018, the rate of suicide in Kansas increased nearly 70%. The 2018 suicide data was the highest in the last 20 years and is higher than the national rate, which increased 35% during the same time period. From 2016 to 2018, we noted an increase in emergency department and hospitalization rates for suicidal ideation related injuries. In 2019, 521 Kansans lost their lives to suicide, causing emotional impact to many more individuals, families, and whole communities, as well as far-reaching medical, economic, and psychosocial implications. From 2015 to 2017, Kansas resident suicides cost an estimated $2.24 billion in medical expenses and work loss, and more than 46,000 years of potential life lost of those dying before age 75. Those disproportionately affected in Kansas include those with lower educational attainment, those living in frontier counties, veterans, and those serving in certain occupations. Suicides of youth is also a growing concern in Kansas. Suicide is the second leading cause of death for those aged 15 to 24, and our syndromic surveillance data shows that Kansas young people visit emergency departments for suicide ideation and attempts the most frequently. From a public health perspective, having an easy to remember 3-digit number to access in-state trained crisis counselors and resources will give Kansans the opportunity they need to seek immediate help in a time of mental health crisis, as well as direction and guidance to ongoing care and support. Resolving a crisis through the National Suicide Prevention Lifeline, or 988 as it will be, can lead to cost-effective early intervention through reduced use of emergency departments and hospital admissions, and reduced use of law enforcement and other safety resources. In addition, when effectively promoted, 988 can also help us end the stigma of seeking care.
Diane, can you summarize at this point, please?
Yes,
We've
ma'am.
only got 2 minutes. I'm sorry.
No problem. The ability to recall a 3-digit number for mental health in a time of emergency or critical need, much like 911, will provide rapid access to intervention services, which may mean the difference between life and death. Thank you again for the opportunity to provide testimony. I will be available for questions when appropriate.
All right, thank you. Then I have Barb Mars, Area Director, Kansas Chapter, American Foundation for Suicide Prevention. Welcome to committee.
Thank you. Can you hear me okay?
Yes, I can, Barb.
All right, thank you, committee members. Thank you for this opportunity to testify in support of HB 2281, which would fund and support a condemnum of crisis response services across Kansas and put in place the state's infrastructure necessary to implement 988. My name is Barb Morez, and I am Area Director for the Greater Kansas of the American Foundation for Suicide Prevention Chapter. We don't know yet the impact of the pandemic might have on our suicide rates, but mental health and suicide prevention must be included in pandemic response initiatives. Suicide prevention efforts must double down, stay the course, and scale up. To have the greatest impact of improving mental health and preventing suicide, statewide crisis services should be a key focus of investments. Members of the committee, we all play a role in preventing suicide, and your support passage of this legislation will confirm the state's commitment to improving the lives of Kansas residents and their loved ones, and to prevent a tragic loss of life to suicide in the future. The Greater Kansas Chapter is grateful for your consideration of HB 2281 for working your colleagues to address and suicide rate in Kansas. We are looking forward to working with you and your colleagues on suicide efforts moving forward. Please ask me any questions, and I thank you.
Thank you very much. Next, I have Gerard Keegan with CTIA.
Madam Chair and committee members, Cheri Keegan with CTIA, the Trade Association for the Wireless Communications Industry. Thank you for the opportunity to testify on this bill and this important issue. CTIA and its members support the designation of 988 for suicide prevention. The wireless industry also understands the need for a workable 988 funding framework. We look forward to working with the committee on language to address the allowable uses of the 988 fund. We would like to understand the particular functions that the 988 fee will support, as the bill language appears to be very broad, which does concern us. We recommend that the fee be tailored to fund equipment and the direct cost of crisis center personnel for call taking and routing. Further, we look forward to working with the committee on language that will ensure the effective collection and administration of the state 988 fee. For example, carriers should be allowed to use a single line item on consumers' bills to collect 911 and 988 fees, so long as there is sufficient separation of both funds to ensure they are not commingled. CTIA would also support the extension of the 988 fee to prepaid wireless services, so long as the collection and administration of the 988 fee follows the point of sale methodology for 911 fee collection. In closing, we look forward to the successful implementation of 988 in Kansas and throughout the United States to help our fellow Americans in crisis. Thank you again for the opportunity to testify.
Thank you very much, Gerald. Next, I have Jeff Cardwell, private citizen.
Thank you, Madam Chair and House Committee members. You able to hear me okay?
I've got you.
Awesome, awesome. So my name is Jeff Cardwell, and I'm here today to voice my support for House Bill 2281. As you mentioned, I'm a private citizen, and I don't have a fancy title behind me in support of this, but what I do have is that my wife and I lost our 27-year-old son, David, to suicide almost 9 years ago. Since that tragic day, we do everything we can to prevent another family from ever experiencing such a heartbreaking loss. If we can save one person, one family, one community, it's worth the effort we take. And when I mentioned community, it's estimated that on average, one suicide loss impacts upwards of 135 individuals. That's astounding. Now, I was very thrilled to hear about the new federal legislation that implements 988 as the new National Suicide Prevention Lifeline number. This legislation will most definitely help to save lives. We, the state of Kansas, must now do our part to help support this life-saving legislation and the funding necessary to ensure that there will always be someone at the other end of the line when perhaps you, me, or one of your beloved family members or friends is in need and reaching out for help. 50 cents a month. Think about that. Only $6 a year. It's a very small price to pay to have that help when needed. Some may ask why this is so important to our communities. And when I say communities, I mean urban, suburban, and rural. The reason this is so important for us to act now is that more than ever, mental health is finally becoming a vital and important part of our overall health. We are finally gaining ground on the stigma that prevents so many of us from reaching out when we are in need of help. Having easier and more readily available help in a time of crisis is critical to saving lives and giving those who may be struggling hope. Thank you for allowing me to testify, and I support House Bill 2281. Let's do everything we can to bring hope to our families and our neighbors. Thank you, and I'll be available for any questions afterwards.
Thank Jeff, and you did pretty great on that 2-minute mark, so we appreciate that.
There you go. Awesome. Thank you.
Next, I have Sheila Albers, private citizen. Are you with us, Sheila? Okay, we don't see Sheila out there. Next, I have Kristin Bray, a private citizen. Kristin?
Hello, yes, I'm here.
All right.
Thank you,
Welcome
Madam
to committee.
Chairperson. Thank you, Madam Chairperson and committee members. My name is Kristin Bray, and I am a public school counselor and also a field advocate for American Foundation for Suicide Prevention. I'm grateful to have the opportunity to speak about my passionate support for HB 2281 in favor of Lifeline 988. The direct 3-digit line to reach trained National Suicide Prevention Lifeline counselors when one is in the midst of a mental health crisis is crucial in order to prevent deaths by suicide. Establishing this easy-to-recall number also communicates the importance of mental health, thereby aiding in reducing the stigma with which it is commonly associated. In 2020, the Lifeline received over 2.6 million calls, chats, and texts. In the midst of a crisis, not everyone is in a position to locate the suicide prevention line or even to do so quickly. According to a Harvard study, many appear to have hastily decided upon and that involve little or no planning. The most impulsive individuals tend to be our youth. Thus, we have no time to waste in making this number available to all Kansas citizens. Suicide is also the second leading cause of death among young people, and in 2016 and 2017 alone, there was a 10% increase of suicides in young people between the ages of 15 to 24 years old in the United States. This issue is important to me because in my 13-year career as an educator, I have personally lost 7 former students to suicide. And my own child has had multiple serious attempts in suicide, resulting in lifelong disability. In my experience, every single one of these adolescents was in an acute crisis with no available resource to assist them. An easy-to-recall number could have helped, saving the lives of our most precious resource, our young people. Thank you for the opportunity to speak before this committee. My passion is fueled by the grief of preventable deaths of 7 young people, and my hope is that my desperate pleas have been met with compassion and understanding. Please know that the AFSP Greater Kansas Chapter and wider suicide prevention advocacy community here in our state is always a resource available to you or to anyone else in need. Thank you for the opportunity to testify.
Thank you, Kristin. Is Sheila with us now? I'm not seeing her up here. Okay. Is there anyone else that had thought they were going to be called on today as a proponent and I did not call upon them? Does that mean you are one of them, Amy?
I am.
Did you not get hold of Dave?
I was wrestling with sending this from within the building on Friday, and I guess maybe it didn't go through. I just want to stand up and say that the Kansas Mental Health Coalition is a fervent supporter of this legislation. Thank you, Madam Chair.
All right. Thank you, Amy. Appreciate it. All right. Committee, you'll also notice that we have written only from 1, 2, 3, 4, 5, 6, 7 individuals and groups. We also have a neutral written by Gina Hummel, Kansas Youth Suicide Prevention Coordinator, Office of the Attorney General. Questions, committee members? Representative Barker.
Thank you, Madam Chair. I'm going to direct my question to the telecommunication gentleman. Assist me with his first name again. Jared. Jared, are you on the line?
I am, Representative.
Thank you. And I agree with you. You made a comment about how the money would be spent, and it's not very well, it's not structured at all. It's pretty vague. What suggestions, if any, do you have? And also, what would be your estimate of the income that would come off of the 50 cents per month or the $6 per year? What type of revenue would that bring in to the fund?
Madam Chair, Representative, on the part of paying for the fund, we would recommend that the fee, the 988 fee on telecommunications customers, be limited to paying for the call center personnel and the routing and taking of phone calls, much like in the 911 space. With regard to how much this would raise, we have not run the numbers on that yet. I cannot speak to the broader telecommunications industry. I can only speak to the wireless piece of the industry, but we could get that information or approximate amount.
Thank you. But you are correct. The 911, that's specifically what it can pay for. This is pretty broad. But thank you. Thank you. Thank you, Madam Chair. Do you have a note, or anyone has testified about what the revenue would be on a 50 cent per month? Do we have any of that information?
Well, we've heard guesstimates that we could be looking at maybe around $3 million or something like that, but I was surprised that I did not see a fiscal note on this bill.
So am I. Thank you, Madam Chair.
All right, thank you. Representative Blex?
Thank you, Madam Chair, and Representative Barker kind of stole my question too, but I also have a question, and obviously we're going to have a initial period to where a lot of getting used to 988 calls. And is there going to be a link from 911, what people are used to, that would, facilitate this interim period? And I also would like to know how the staffing is going to be. Is there going to be like a call center, going to have people on staff? Do we know any of that? And, on that response?
Is that something you can handle, Monica? Yes, come back up here, please. And actually, I had that as one of my questions, Representative Black, so.
Thank you, madam. Makes me feel smarter.
Yeah, don't let that do that to you. Not from my direction anyway, sir. Welcome to committee.
Thank you. So I believe that the second question was, would there be a center and would we be staffed?
Yeah.
Can I take that one first, and you can remind me what the second one was? So yes, at this time, you have 2 hotline centers that are answering National Suicide Prevention Lifeline calls, and 1 center which is in the application process. So it is my organization, the Kansas Suicide Prevention HQ, and ComCare of Wichita, where we have phone staff that is dedicated to answering this line. Johnson County Mental Health is currently in an application process and plans to answer for Johnson County calls in a similar way that ComCare of Wichita answers for Sedgwick County calls. All of those then roll over to us. We operate at a 24/7 level, which means that we do have folks in our call room 24 hours a day, 7 days a week. We have a rigorous in-house training process, which is in compliance with both our accreditation body and also with the National Suicide Prevention Lifeline standards. This bill would actually take things like 1 step farther and make some specific requirements around having training for our counselors to be able to interface with populations that have historically higher rates of suicide. I think that the 2 that are outlined are specifically those with LGBTQIA identities and also our rural populations, which we find have significantly higher suicide rates. Does that answer that question?
Yes, if I can have a follow-up, Madam Chair. Currently, you do have some data. How many staff are you having? I mean, you said 24/7, that takes a lot of staff. And, you know, mental health, as I understand it, has a lot of diversity in what go. Do we have 1 person or 2, or what does it take to answer that person's questions effectively, since you do have some data?
Sure. So we typically staff our call room with between 1 and 3 people at any given time. We find that, for instance, starting at about 4 p.m. until about 2 a.m., we take a lot more calls than we do during the day. And so we need to have more folks there. The way that the model operates is that we actually prepare the person to answer that is answering the phone to do the whole intervention. So what a person can expect if they call the National Suicide Prevention Lifeline, soon to be 988, is they'll be connected with someone who can help them to start to describe the nature of their crisis, do a suicide risk assessment, and then based on that assessment and any considerations for the imminency of risk, create a plan about what to do next. Sometimes that looks like us partnering with our law enforcement partners or 911 centers to start an active rescue. More often, what that looks like is using good crisis counseling skills to help to de-escalate that person, help them to agree to safety, and then creating a collaborative safety plan that can be executed by the individual's supports, and the individual's treatment providers. We also then connect folks to ongoing mental health services.
Thank you for that. Thank you, Madam Chair.
Representative Lynn?
Thank you, Madam Chair. I think my question might be for the revisor's office. I just wanted a clarification on the fee. It says 50 cents per month per subscriber. Can you define subscriber? Is that per line or maybe per household?
Representative, I'll look into how that's handled on the 911 fee. I'm not completely clear how that is structured per subscriber in that kind of setup there. So I will look into that and get back to you.
Thank you. Thank you, Madam Chair.
Jared, is that something that you can help us with? Because I think it goes along with, are we talking all cell phones? Are we talking landlines? Are we talking per phone? Are we talking per account?
Madam Chair, our reading of the bill is that it would be per line. So if you had a family plan with 4 lines in the cellular space, that would be 50 cents per month times 4 lines. And it would be inclusive of cellular, landline, and VoIP. It currently doesn't include prepaid wireless. As I said in my testimony, we would support the inclusion of prepaid wireless as long as it followed the 911 point of sale methodology that is currently in place with Kansas.
And how does the 911 process work? Can you enlighten us on that, please?
So in the prepaid space, Madam Chair, the customer purchases their prepaid product at a retail location. The retailer then collects the 911 fee as part of that transaction because the customer has little to no interaction with the prepaid provider. They have the interaction with the retailer at the point of sale. So that's why we would support the extension of the fee to prepaid as long as it had the point of sale methodology and the retailer was allowed to put on the receipt one line item that includes the 911 and 988 fee to make administration and collection more efficient.
All right, thank you. Does that answer your question, Representative Lynn? Next, I have Representative Reese.
Thank you, Madam Chair. My question is for Monica.
Go ahead,
I can't
Monica.
tell if Monica's at the stand.
She's up. She's there.
Okay, all right, good. I need to see her beautiful face. Monica, I have a question regarding your trained crisis counselors.
Yes.
When someone calls in and is speaking, Spanish or any other language, how is that handled?
So we have a couple of different options. There is a Spanish language lifeline that is answered by a network of centers that is identified by Vibrant Emotional Health. They're our administrator of the National Suicide Prevention Lifeline. Also through membership of that network, we have access to live translation services. So we're able to collect some information, access that similar to any healthcare provider and navigate a phone call in that way. What my center has found is that we have not been able to reliably staff languages other than English, and so we've been reliant on those translation services despite having some multilingual folks.
Okay, and I reading the bill, I didn't see anything in there that makes that a requirement of any of the entities that are going to be, taking the calls, like headquarters. That it would be required to have bilingual staff or having something that's more reliable for translations. Am I correct in that?
Based on my reading of the bill, you're correct in that. I to be perfectly honest, would refer us to the services that we have, that Lifeline centers have the capacity to access through the national organization, which is likely why we don't see it in there, because as a part of that application process, you gain access to that support. But it could be an oversight, absolutely.
And how awkward is it, when you have to go through the translation, like that Lifeline, the Spanish language Lifeline?
The Spanish language Lifeline. Yeah, so the Spanish language Lifeline is a 10-digit number that we advertise alongside our Lifeline, so that is seamless. If Spanish speakers are accessing that 10-digit number, then they're answered in Spanish. As far as the translation services, it does require some wrangling on the part of our counselors to be able to access that for sure.
But going to the 988 number, how is that going to work with the Spanish language?
I would have to go find those answers for you. That's not something that I've heard explicitly talked about from our national organization.
Okay, if you could find that research or that information, that would be very helpful.
Yes.
Thank you. Thank you, Madam Chair.
You're welcome. And I'm kind of wondering if it doesn't have something, maybe perhaps that's tied in with our federal legislation or something. And I don't know if there's anyone that was a proponent today that can find that answer for us, or perhaps Revisor Abbott could do that as well. Representative Barker and then Representative Turner.
Thank you, Madam Chair. I got a couple of questions. One for the revisor. If you could supply maybe the committee with how the 911 structure is as far as what they can use the money for. Did you get that? Are you on?
Yes, Representative, and I was just pulling up the statute that directs the expenditures of the 911 fee. So if you'll just give me 1 second.
Oh, you can supply it later. If I don't think we're working this bill today. So
We were hoping to, but no.
No. Okay, good. And one more, one question for Monica, if you could. Okay.
Yeah, so Scott, just go ahead and look that up and then take and supply that to us.
Give that to the chair lady and she can get it out to us.
No, give it to Dave. Don't give me anything. Okay. Scott knows that.
Okay. Now we all do. Monica, you're in existence now.
Yes.
You're going to get, if this passes, you're going to get some more money. What is your personnel now, and what is your budget now? And where do you get that money from?
Absolutely. So I want to say first that regardless of whether or not this bill passes, 988 does come into existence, and we do see more Kansans relying on that hotline service. So that happens regardless of what happens with this bill. Our budget at this point is just a little over $1 million. We have creatively braided together funding sources. Committee members may or may not be aware that hotline services in Kansas are not currently eligible for Medicaid billing, so we can't bill any insurance companies for the services, the mental health services that we provide. So we are funded through a variety of grants, both from our partners at the state, at the KDADS level, private foundations, and then our national organization, Vibrant Emotional Health, has also funded some grants. And then my program actually provides some fee-for-service training components that we use to supplement our budget.
One quick one. Do you work with the VA? Because the VA has a very, very effective suicide.
Yes, so the Veterans Crisis Line, currently when folks call the 10-digit number, veterans are given an option to press 1. So we do see veterans that self-identify as veterans and are connected to the Veterans Crisis Line. That is a bit of a different structure than what civilians have access to, because what the VA has been able to do, what the federal government has done, is has appropriated money specifically for those services. So we have 3 national centers that answer for the Veterans Crisis Line, while civilians or folks who are veterans but choose not to access the Veterans Crisis Line are connected to this more broad, not consistently funded network of centers who are having to braid together funding in a different way. But we would continue our partnership with the Veterans Crisis Line.
Thank you so much. Thank you, Madam Chair.
Well, and I might add, Representative Barker, if you look on page 4, on lines 9, 10, and 11, it says, continue to work with the United States Department of Veterans Affairs to route calls from self-designated veterans for the provision of the VCL. So, but that's a good point.
Thank you, Madam Chair. I did bring that up because anytime you call any veterans clinic, that's one of the first things you hit 1 for the Veterans Crisis, and I want to make sure there's a collaboration between the two.
Absolutely. Okay, then I have Representative Turner.
Thank you, Madam Chair. A question, I guess, also for Monica. The 50 cents, how was that number arrived at?
So myself and in partnership with the folks at the Kansas Department of Aging and Disability Services did sort of a survey of what we see going on at the national level with regards to how this fee is being identified, and really found that 50 cents was kind of middle of the road. And so I, have heard a couple of times now that we're referring to how 911 fees are utilized and the differences with 988. So there are some similarities, because of how the feds decided that we could go about seeking funding for this service. A primary difference that I would draw the committee's attention to is that 988, were it to exist on its own without a crisis continuum of services, cannot be as effective without those crisis continuum of services. So we are doing a bigger job with this fee than just the hotlines. We are also looking to support, as you heard Commissioner Brown say from KDADS, the governor's proposed crisis teams. We're also looking at if we cannot resolve crises in the community, if we're not looking at an outpatient appointment, where can those folks go And as an alternative to higher cost interventions like emergency departments or inpatient hospitals or state hospitals. And I think we're all aware of the limitations there. And so having some additional funding for things like mobile crisis teams or crisis receiving facilities, we think will really improve the experience to be a less traumatic experience for folks who are in crisis, but also overall a money saver because we would be able to divert some of those higher cost interventions.
One follow-up, if I can. So to Representative Barker's point that you call VA and you press 1 and you go here, is there any, I don't know if there's other organizations thinking of dedicated lines, you know, at a national level or at a state level, but is there any leveraging of like a 911 so that you can, was that ruled out, I guess?
So what we find from SAMHSA's best practices when we look at that is what you really want is for calls that come into a service like 988 to be fielded by mental health professionals. You want folks who have that level of training. And we ask 911 dispatchers to have a very different level of training and a different capability of that. So what this is really looking at doing is just trying to help folks get connected with the person who can help them best, and also to reserve services for the way that they should be utilized, right? I want our 911 dispatchers to be able to take the calls that require fire and med dispatch quite quickly. So we have been having my organization, I won't speak for ComCare and Johnson County Mental Health, but my organization, we have been collaborating very closely with our local PSAP or our 911 center, as well as starting conversations with the 911 dispatch professional organization who have indicated to us that it feels like very good news to be able to get some folks who require mental health supports over to us rather than staying with the 911 PSAPs.
Thank you, Madam Chair.
Representative Hasswood.
Thank you, Madam Chair, and this one is for Monica. Sorry, one more. Thank you so much for coming here today. With the partnership with the VA, is there going to be a coordinate, consistent public messaging with Indian Health Services?
I would say a yes with a caveat that we have been really coordinating very closely with Vibrant Emotional Health, our national administrator, and the Substance Abuse Mental Health Services Administration on what those coordinated messages will look like. So again, I will speak for my organization. We coordinate very closely with the Indian Health Services in Lawrence and with Haskell Indian Nations University. We find that that's a very important partnership to have and have worked very hard to look at the kind of cultural competency that we have at our center to be able to interface with Indigenous folks and really look forward to continuing that partnership and sharing some of that experience with our other network centers.
Thank you. I know we lost a couple students on campus, and I look forward to this. Thank you so much. Thank you, Madam Chair.
Don't go away, Monica. Okay. If calls come in, which this is going to happen for a long period of time, to 911, they can switch it to the 988. Is that correct?
We are working on the technology solutions to enable that to happen. So currently, PSAPs, my understanding of this technology, and if there is anyone from APCO or NINA here, I would absolutely defer to them. My understanding of PSAP technology is that they have an ability to transfer to other 911 centers, but they have difficulty transferring to outside lines. So we are actually on the 911 Coordinating Council's agenda for an upcoming meeting to talk about what it's going to be like to start passing those phone calls back and forth in a more efficient way. But we anticipate that there will be some not insignificant technology costs that will incur trying to make that happen.
Well, it seems to me if it doesn't work that way, we've got a problem. The other question is, all right, because there's discussion in here of the mobile crisis services. How are those going to be made available everywhere?
Through close partnership with our partners at KDADS. So I know that it has been a significant recommendation from those folks for a number of years now. And I have a personal interest in seeing those teams be available to folks who live in our not suburban or urban areas and know that there is a significant need there. But the bill, I believe, states that the responsibility for convening those teams would be on KDADs.
Which means we really don't have an answer because there's not a funding mechanism for that.
Yes, that's one of the reasons that we're so strongly supporting the imposition of a phone fee.
But I'm not sure that that 50 cents is going to cover what everything else is in this bill.
Madam Chairwoman, not to interrupt, I would encourage you to speak with Commissioner Brown or other folks at KDADS. My impression of the 50 cents per line is that it would be a significantly higher amount than $3 million that would be generated. That $3 million is what we anticipate needing for the hotline services.
Right. Okay. Well, but I think this goes back to testimony we heard from another conferee on having specific designation on how that 50 cents is spent. So that's a discussion that we have to have. And then if I look on page 3, lines 13 and 14, and I'm sure Andy's still on there. And Andy, tell me if you disagree with me, but this would be a high price tag. Fund any uninsured services provided in response to the hotline if an individual receiving the services is uninsured or the services or the facility are not covered by an individual's insurance. Would that be correct, Andy?
Correct. Yes.
And are you guys assuming that this can be covered within that 50-cent fee?
So KDADS has been working with the governor's office on the governor's budget. We've included $8 million between DCF and KDADS in the governor's budget recommendations for mobile crisis services. So that $8 million would be the base for those uninsured services. And then in addition to that, as we look to move forward with CCBHCs and those crisis programs, CCBHCs are required to provide services to uninsured individuals that present for treatment. So what we would do is mostly make sure that our referral system was directing people towards CCBHCs, and the mobile crisis teams would be screening folks for state hospitalizations.
Well, then we could use some help from KDADS to bring that fiscal on the CCBHCs out there. That's an obstacle right now for a whole lot of people in this building. And it's very frustrating because we do know how important that those are. We do know that there's a lot of debt offset that can be made to that, just like there's been assumptions on Medicaid expansion, but for some reason we don't have those numbers in here. So that would be a major concern. Is Diane Zolick still with us?
Yes, I'm still here, Madam Chairman.
Diane, when will we have the 2020 suicide data?
I would assume that will be ready toward the middle part of summer, but we are looking at that provisionally and comparing 2020 and 2019 years do not see a significant increase in the rate of suicide at this time.
So you're not seeing with what you've looked at so far in the 2020 an increase in suicide?
Not when comparing 2020 and 2019. That's correct.
Okay. All right. Thank you. I think that's all the questions I had. Has anyone else got further questions on this? Representative Blex.
Madam Chair,
Did somebody hit a button on you? Is that what happened back there?
Yeah. Madam Chair, we never did follow up on, from Scott on the question on 911.
He's going to provide that to the committee.
He's going to provide that, okay.
Yeah, that way it gives him some time to actually get in it.
All right, thank you.
And pull that data, because it's worth looking at. Are there further questions or comments on the bill? All right, committee, that closes the hearing on House Bill 2281. And we're kind of running short on time. Something tells me that we may run into some problems tomorrow as well. My goal is to actually try and work. If you got a pen handy, you want to know what's going on, is for us to work House Bill 2209, 2256, 2279, don't have heartburn over there, Representative. House Bill 2280. We just did 2234, and then 2259. I think that one's going to need some amendments. And then, of course, House Bill 2281, that appears that it probably needs some amendments. Now, everything is subject to change, but that's where we're at right now with everything. All right, committee, we are adjourned till tomorrow at 1:30.